So this is was like a few years back. This is before the era of DALK, patient with keratoconus and the like regular keratoplasty. The first suture was taken by the fellow, and he took quite a few minutes to get the second suture. He was trying to get a perfect suture, and you can see a kind of hesitation in his hands moving and adjusting here and there. And we counted on replaying the video. It was almost 9 minutes. So the patient has moved at the time. It was a general anesthesia, and somehow he squeezed, so with sudden shallowing of the AC, mydriasis and protrusion, start to protrusion of the ocular contents. And you can see you can feel the coronary spasm here and the panic. He's trying to do anything to close the eye. At this time, the nurse kind of rushed. The circulating nurse kind of rushed. We need your help. I was operating next door, so I moved in and tried to take a second suture. While I couldn't, I put some Helon under the graft, and everybody was under severe stress at the time. What next? What to do? So I kind of, put the globe together in a way, in an incomplete and maybe an incompetent way, and transconjunctivally, I just stick a 20 gauge MVR, and I did a limited core vitrectomy just behind the lens. And you can notice that the things would go nicely back in position. The pupil will start to narrow, and we had actually like a redundancy in the anterior chamber. So now we can go quickly suturing the eye. So the 6 o'clock suture slipped, and eventually it was done quickly, and we could save that eye that had, I think, like a partial expulsive hemorrhage from the anesthesia, and the patient improved vision to 0.8. So the take-home message here is, in life, we have to deal with our own fears and incompetencies and move on. But while dealing with patients, I think our imperfection has to be met as well. And we have to face our responsibilities, and also the sensation of guilt that makes the decision difficult to produce. And also we have to remember that we are not perfect. We have to move on, and certainly do not panic. We have to improvise. If the anterior chamber will not be closed entirely, so we'll do it partially and figure out a way to move on and save the eye. Yesterday talks about the Coats disease just made me put the initial paper. It was published online in 2009, about 17 cases, drained transclerally, and with very good results. So this is the paper. And for those of you who are interested in pediatric retina, we are hosting a meeting in Cairo at the end of March next year. Dr. Shingul and Susanna is going to be a guest to the meeting, along a list of other people. And the meeting is combined with an oncology meeting, the second Middle East oncology meeting. So hope to see you there. Thank you very much.